If anybody cannot see their screen, they can send us a message on the chat window. Excellent. Thanks, Dibbendu. Thanks, Dr. Radhika. So everyone, we will get started in just a couple of minutes, but the process will follow is basically if you have questions, shoot them in text on the chat window, and somewhat in the middle of the talk, Professor Amanda will pause a little bit and take some clarification questions on the 20th or 25th minute. And then a final round of questioning can be done after 40 minutes of her presentation. So that's the way I will do it, and I will read out the questions for Professor Amanda to respond at the end of both these intervals. And when I officially start, I will also again mention it for everyone who is participating. Rajesh, I hope the recording is on for audio and video.
Yes, Professor, it's on. Yeah.
Okay, excellent. Thank you. Okay, let me, there's a chat message. Someone has said something to somebody about some name. You can figure it out. But the point is that I think the time has come to basically kick off the seminar. So let me just start that process. Thank you everyone for joining in today's first virtual healthcare research seminar series from the Center for Management of Healthcare Services here at IIM Ahmedabad. We have with us Professor Amanda Starc today from Northwestern University, and I am going to moderate the session, opening it up for Professor Amanda. And I'm Chirantan Chatterjee from IIM Ahmedabad. Before we go ahead, let me also make a special mention of the support that we have received from our CMHS team, our information technology team led by Rajesh, and our communications team led by Deepak. Also, I'm very supportive to the leadership of IIM Ahmedabad and my executive committee at CMHS and faculty colleagues here at IIM Ahmedabad in facilitating, in organizing what is perhaps the first such experiment of a virtual healthcare seminar series in the country. So today, it's a great pleasure to have Amanda with us. Amanda is an associate professor of strategy at the Kellogg School of Management and a faculty research fellow at the National Bureau of Economic Research. She's joining us straight from Chicago. She received her BA in economics from Case Western Reserve University and her PhD in business economics from Harvard University. Her research interests include industrial organization and health economics, and she examines the Medicare Advantage, Medicare Part D, and Medicare Supplement markets, as well as consumer behavior in insurance exchanges. Some of her recent work measures the effectiveness of direct-to-consumer advertising of pharmaceuticals, and her work links models of consumer choice and supply side incentives and uses a range of econometric techniques to analyze data. Well, that's the official note that she had asked us to share with you, but I would like to mention that she has several top quality economics publications, including at the Rand Journal of Economics, Review of Economics and Statistics, the Review of Economic Studies, the Journal of Health Economics, the Journal of Public Economics, the American Economic Journal, among many others. So thank you very much, Amanda, for giving us time for sharing your latest research findings. And it's over to you. The plan is basically to have overall 40 to 45 minute talk by you, and then we will have 15 minutes of Q&A moderated by me. We will try to pause about at the 25th minute to take some clarification questions in case participants have one. Thank you, Amanda. Over to you.
Great, thank you so much for having me. It's pretty early here, so I apologize in advance if I grab some coffee intermittently. I'm excited to present what is relatively new work, thinking about mortality effects of health plans, and this work is joint with Jason and Mauricio and Peter. All right, so the starting point for this paper is that in many markets, firms choose not only the prices of their products, but also product quality. And the thing about product quality is that it's often difficult to observe. And when that is the case, when consumers especially don't observe product quality perfectly, consumers and producers may make suboptimal choices and investments. Consumers may not flock to high quality products when they're willing to pay for them, and producers may not invest in producing high quality products. Now, of course, nowhere is the problem of quality observation more difficult than in healthcare markets. We can think about this in a variety of settings within healthcare, whether choosing providers, or today we'll think about choosing health insurance plans. And when I think about the quality of your health insurance plan, we often think of insurance as a financial contract, but increasingly we have evidence that insurance can have real impacts on health as well. And today we're going to define quality as a causal impact on health outcomes that we care about, specifically reduced mortality. All right. So we care about this because quality is difficult to observe, because if we have a hard time observing quality, that will make the expansion of high quality firms more difficult. And ideally, competition, say, among health insurers will lead to either higher quality or lower prices, or both, and possibly for some innovative contracts. Now, when we think about quality, I mentioned that quality might be difficult for consumers to observe. Of course, quality is going to be difficult for the econometrician to measure as well. Why is that going to be the case? Well, I want to ask the question, can your health insurance plan actually make you healthier? And in order to answer that question, I'm going to face two really thorny problems. First of all, in the setting that I'll be talking about, and in many settings, consumers of different health will sort non-randomly into plans. So we'll need to worry about selection. Now, when we're worried about that type of selection, maybe what you might want to do is run a randomized controlled trial. That's going to be the gold standard for dealing with those kinds of selection problems. What's the problem with thinking about an RCT in this setting? Well, RCTs are typically small scale. They're going to be underpowered to detect systematic health effects, and especially rare health events like mortality. And just to preview, we'll think about this in the setting of Medicare within the US. And so in order to show you some estimates today, I'm going to need to leverage the universe of Medicare enrollees to give you a sense of the scale we'll need to have some power. So in this paper, we're going to address these twin issues of selection and power by leveraging quasi-experimental variation that comes about from changes in consumer choice sets as a result of plan terminations, plans exiting the market. And I'm going to argue that that's largely for policy-induced reasons. We'll develop a framework for using this variation to measure the predictive content of the observational estimates. So in this way, I'll be able to knit together both quasi-experimental estimates and observational estimates. In doing so, we're really building on a literature that has gained a lot of traction both in education and increasingly in measuring health outcomes in the hospital setting. And this is really coming from measuring value added, and there's a wide variety of papers on this, and that's where our econometric inspiration will be coming from. Okay, so let me tell you a little bit about the research questions that we'll be aiming to answer and give you a brief preview of the results. As I mentioned, the main question today is going to be one of measurement. Do some insurance plans reduce expected beneficiary mortality more than others? I'm going to argue that that is not only true, but that the variation is significant. Standard deviation in the causal impact of plan enrollment is about 20% of the mean. So a natural question is, if there are these big differences across health insurance plans, what drives those quality differences, and what might consumers use as proxies? I'll argue that the existing rankings that exist are mostly weakly predictive of true quality, although they'll be correlated with the observational measurements. And so we'll want to think about the possible mechanisms that come about from primarily financial generosity and network breadth. Last but not least, we want to think about how effective consumer choice is in this market. We'll develop a method in order to estimate the implicit value of a statistical life that the consumer is sort of trading off against premiums. And what I'm going to argue is that consumer choice definitely does improve health outcomes. Consumers do better than random in this market, but there are potentially large gains that could be made from improving consumer choice. I'm going to tell you a little bit about the setting. In the interest of time, I'm not going to talk a ton about the setting, although I'm happy to take clarifying questions. So we're going to think about this in the context of Medicare Advantage plans. This is within the Medicare program within the US, which covers Americans 65 and up. In that program, while we often think of that as being provided by the federal government, beneficiaries actually have a choice. They can choose to go with a traditional fee-for-service plan. You can think of that as a public option, or they can choose from a broad array of subsidized private managed care plans. Those subsidized private managed care plans are going to be differentiated on a variety of dimensions. I talked on the previous slide about the extent to which financial generosity and especially prescription drug coverage might be an important mechanism underlying the variation that we see in the data. There's also going to be differences in networks of both doctors and hospitals. And these plans will have different premiums that will allow us to gauge the extent to which consumers trade off premiums versus quality as defined by reduced mortality. Now, the subsidy in this market is so generous that the premiums, I should mention, are sometimes zero. So a wide array of plans available. And we're going to leverage data on the universe of Medicare beneficiaries. And so while we're not going to observe claims for everyone, we are going to observe enrollment and mortality outcomes for the large number of consumers in the Medicare program. The one thing I'll say about this program, just to fix ideas, is that you should care about this program in and of itself. It's a big program. So as of last year, it's going to enroll about 22 million people. That's about a third of all Medicare beneficiaries. So it's a large program, a lot of folks in it, and so we should care from a policy perspective as well. Okay, so our first question today is, do some insurance plans reduce mortality more than others? So we're going to want to think about measurement. The first thing that we're going to need to do from a measurement perspective is to construct an observational estimate of average mortality. We don't think this is really capturing the causal impact of plans because of those selection effects that I talked about earlier. Nonetheless, we want to construct it and then use that to think about its predictive ability when thinking about the true causal impact. Okay, so in order to construct those observational mortality estimate and mortality added measures, what are we going to do? Well, you should think of this as just running a regression of mortality down on a bunch of fixed effects. Okay, so we're going to regress YIT, which is an indicator for whether or not an individual I died in year T. We're going to regress that down on a set of fixed effects that's being captured by this D sub I sub J sub T, which is equal to 1 if individual I starts year T in plan J. We'll control for what we observe. Right, so controlling for what we observe is going to be important. So we're going to have a vector of basic individual controls. These are primarily going to be demographics. We're going to control for flexible functions of age, for enrollee race, for enrollee sex, and importantly, in all of our specifications, will include county and year fixed effects. So this is always a within market comparison. That's going to be important in part because we think that there's variation across the US in underlying mortality. And also when we're thinking about comparing two plans in terms of their quality, we really want to compare two plans in the same choice set. And of course, we're not capturing everything that we think is likely to be correlated with plan enrollment. There's an error term here, epsilon IT, and that error term, that regression residual, is likely to be correlated with d sub I of j of t, which is going to generate that selection issue. The last thing I'll say here is that we're going to, mortality is of course a noisy outcome, and because mortality is a noisy outcome, we're going to use some standard empirical Bayes shrinkage methods that will just shrink our estimates to the county mean if they are really noisy. All right, so we'll get to some initial results pretty quickly at least. So what have I done on this density plot? Well, on this density plot, I am just plotting those mu's. Okay, so I'm plotting shrunken observational mortality added. There's a couple things to take away here. The first thing to take away is that before we add any controls, okay, we have a pretty wide range in terms of observational mortality effects. Of course, the mean is a little bit less than 0. And yet I told you I demean by county. So given that I demean by market, the natural question is, why is the mean less than 0? The mean is less than 0 because I'm only plotting this for Medicare Advantage and not for the traditional Medicare program. And so from what you should take from this is that enrollees in Medicare Advantage are a little bit healthier than those in the traditional Medicare program. Now, I am going to want to control for those demographics. Once I control for those demographics, okay, we get a little bit closer to 0. So the enrollees in Medicare Advantage look a little bit more like the enrollees from traditional Medicare. And the distribution gets a little bit tighter. Nonetheless, what are we seeing in terms of standard deviation? Well, the standard deviation across plans is about 0.8 percentage points. To give you a sense of what that means in practice, average mortality in our sample is about 4.7% in any given year. And what that's saying is that the standard deviation across plans is almost 20% of the mean. So there's actually a great deal of heterogeneity here. Enrolling in one insurer's plan relative to another, it seems to be correlated with big differences in mortality. Okay. All right, now, of course, I said that's going to be hopelessly contaminated by selection, and so we're going to want to think about how to validate those observational mortality estimates. Okay. And so in order to do that, we're going to leverage some plan terminations. Those are going to provide some additional quasi-experimental variation. How am I going to think about this? Well, we're going to see a number of policies during our sample period that are going to affect insurer entry and exit decisions. Because these are primarily driven by policy and not things that are going on the demand side of the market, we believe that this will provide some clean variation. Of course, I'm not going to ask you to just take my word for it. I promise to show you lots of evidence on this in a few slides. So just to give you a sense of the type of variation that we're using, in 2008, legislation was passed that led to the unexpected exit of many large so-called private fee-for-service. This is a class of plans within the Medicare Advantage market during our sample period. We know that most of the enrollees that are in these plans that exit the market are going to, in fact, switch to a different Medicare Advantage plan. Now, we also know that absent terminations, Medicare Advantage enrollment is highly inertial. So you're likely to stay in the same plan next year that you were enrolled in this year. We can take those facts and put them together in order to think about validating those observational mortality added estimates. So let me just walk you through a simple example and then I'll take some questions. Okay, so the idea that we're going to have is imagine a market with 3 plans, plans A, B, and C. We're going to think about plan A as having 5% mortality, plan B is having 3% mortality, and plan C is having 2% mortality. Then we're going to think about what would happen if plan A exited the market. Okay? Again, we think of this as being due to plausibly exogenous reasons that's coming about from policy variation. Well, when Plan A exits the market, something has to happen to the folks that were previously enrolled in Plan A. And we think that they're likely to switch to other Medicare Advantage plans. Okay, so in my simple example, half of them are going to go to Plan B and half of them are going to go to Plan C. So now we want to think about what happens in the world where now in this market, we just have Plan B and C. If the observational mortality added estimates I just calculated are predictive of the true causal effect, we would now expect that the enrollees in Plan B and C are going to be less likely to die because Plans B and C have lower mortality than Plan A. So if this is a true causal effect, when we move the enrollees that were previously in Plan A to Plans B and C, we expect mortality to fall. In this example, if this was entirely a causal effect, we would expect mortality for that cohort to fall by 2.5%. Now, of course, if in the observational data we see that mortality falls by 2.5 percentage points, I haven't actually identified the causal effect of either Plan B or Plan C on your mortality. Why is that? Well, I can show you 3 simple observationally equivalent scenarios. The first is the one that I showed you in the figure where Plan B has 3% mortality and Plan C has 2% mortality. The second scenario is one where they both have an equal causal impact of your mortality and a mortality rate of 2.5%. The last is one in which Plan B is exactly like Plan A, but Plan C actually makes you immortal. All of those will be observationally equivalent if those enrollees move into Plan B and C in equal measure. And so what we're going to do instead is we're going to put a bunch of these different terminations together. We're going to leverage the fact that we see not just Plans A, B, and C in one market, but Plans D, E, and F in another, and so on and so forth. And we're going to ask the question, how well does the observational mortality added estimate predict what we think the true causal impact is? Okay, and I'll be much more formal about this in a second, but just 2 more figures to build some intuition. Okay. The first figure is one that is going to plot the observational mortality added, that mu from the previous slide, of the plan that you're enrolled in over time. Okay. What we're going to do here is we're going to break out the sample into enrollees that pre-termination are enrolled in better than average plans, that's in red because lower mortality is good, and worse than average plans, that's in blue, higher mortality is bad. We know in the dashed line that folks are likely to stay put, so that's a relatively flat line, if their plan does not terminate, does not exit the market. By contrast, if your plan exits the market, there's just a mean reversion going on. If you're in a high mortality added plan and that plan exits the market, you're more likely to end up in a more average looking plan. If you're in a low mortality added plan and that plan exits, you're more likely to also end up in a more average looking plan. Now, if these estimates had any predictive content about the true causal impact, okay, we would expect that when we move those enrollees into those more typical looking plans, that would change the mortality rates for those cohorts. Okay? And so we're going to take this measure of plan quality, which you can sort of think of as the first stage, and we're going to think about what then happens to true mortality at the individual level. And you could think of this as sort of the reduced form of the IV regression that I'll eventually run. And so in practice, what do we see? Well, we see that the folks that are in terminated plans, if you were in a bad terminated plan, you're likely to enroll in a more average looking plan. If that has some predictive content, we expect your mortality to fall, and in fact it does. Okay? And vice versa. If you're in a low mortality plan that exits, you're more likely to end up in a worse plan and slightly more likely to die. I'll be much more formal, okay, about what this means in practice once I introduce the model in just a So we looked at what happens to the plan you're enrolled in. We can now look at the individual outcomes. And while it's not perfect, those individual outcomes tend to track the underlying plan effects, and therefore we think there might be some predictive content here. All right, with that, I'm going to stop and take some clarifying questions. Do you want me to read them off of the chat? Okay, I'll take them right off the chat. Okay, there's a question about what types of medical conditions Medicare Advantage covers, and whether or not we should expect a mortality effect. You should think of Medicare Advantage as covering a whole host of medical conditions, including hospitalizations, doctor's visits, everything that the traditional Medicare program would cover if you were enrolled in the traditional Medicare program. So this is covering essentially all of your healthcare services. And so what we are working on currently is thinking a little bit about the second half of this question, which is, you know, do we think there are places or conditions where mortality is more likely? And if that's the case, do we see heterogeneity in the effects that we measure across those different outcomes? There's also a question about whether or not there's a role for congestion, sort of capacity constraints, primarily at the healthcare provider level. I think that's a good question. We're also working on it. So what we'll do in practice today is I'll show you some simulations of what we would expect if we moved consumers into measurably better plans. I'll do a simulation where I move consumers into the best plan in their choice set. Now, the problem with that is that we should absolutely be worried about these congestion effects. And so I'll do some other simulations as well where we think congestion is less likely to be an issue. So, you know, moving people from the 25th to the 75th percentile. And so we're definitely worried about this issue, and I'll do my absolute best to tackle it in the simulations, and I think an interesting avenue for future work. Good. Any other questions?
No, I think you can go on, Amanda.
Oh, all right. Sounds good. All right. So I'm going to go ahead and introduce the empirical model. So the first equation here should look familiar. We have an outcome equation. We're regressing Yij, where Y is mortality of consumer I and plan J, down on a set of fixed effects, consumer controls, and we have an error term. But we're not interested in mu per se. What we're really interested in is an object that we're going to call beta Ij. And that's the estimated expected mortality if all consumers in a market were enrolled in Plan J. Right? So we want to get rid of this selection issue. So we can write beta Ij as the expectation of Yij unconditional on plan enrollment. Okay? What would we do if we observed beta J? Right? That's sort of the whole measurement problem here. But if we observed beta J, we would regress it down on mu J, okay, and see if mu J and beta J are correlated. We're going to write this out as beta J is going to be equal to some constant, which we'll later suppress, plus a term lambda that measures the predictive content of mu, plus an error term eta. This error term eta will come back in a second, and I promise to. So what are we going to do in practice? We're going to take our infeasible regression. We're going to, as I promised, suppress that constant. Okay, we're going to take the infeasible regression, plug it into that potential outcomes measure. And so now we can write YIT equal to beta J plus times the plan indicators plus some individual controls. Okay. So when we do that, plug the infeasible regression in, what do we now have? We have YIT as being equal to this lambda term, which is what we're ultimately going to be interested in measuring, times mu IT, the observational mortality added, plus our individual controls, plus this error term eta, plus the error term epsilon from the outcome equation. So what are we going to do? Well, we're going to try to estimate lambda via two-stage least squares. So in practice now, we can think of yi, where I'm going to suppress the j notation as well. Okay, so yi is being equal to lambda times mu. Plus, we're going to control for some things like what plan were you in last year? Was it high or low mortality added? Did your plan terminate, right? So there could be a direct effect of termination. Plus those individual controls, plus eta, plus epsilon. This is the equation that we'll actually take to the data. Now, of course, the whole problem here is that mu I is endogenous. And so we're going to think about predicting mu I, okay, using an instrument. Okay? And our instrument is going to reflect the diff and diff type pictures that I showed you a minute ago. If you're in a high observational mortality plan that exits, you're going to be more likely to be in a more average looking plan the following year. What's the intuition behind this two-stage least square regression? Well, the idea is that if mu is unbiased, okay, lambda equals 1, because remember our infeasible regression, if lambda is equal 1, then mu I and beta I are going to be highly correlated. We should be able to predict the reduced form effect of plan terminations on mortality, okay, with the first stage effect of mortality added. So what that's saying is, in the pictures that I previously showed you, convergence in mortality added should also lead to correlation in the true mortality, convergence in the true mortality outcome. Okay, I fumbled through that. I'll show it to you again when I show you the results. We're going to take the model that I showed you, port it into a two-stage least squares framework. We're going to estimate an IV regression. The idea that we have in mind is if I change the mortality added, do I change the actual mortality outcome? Okay. So will this work? And what am I going to need in practice? Well, I'm going to need a couple of things. So we're going to formally need that the covariance of our instrument Zi, okay, with eta I plus epsilon I is equal to 0. There's two pieces to that. The first piece is going to be the standard exclusion restriction, that the covariance of Zi and epsilon I is equal to 0. That's going to be the case if plan terminations are as good as randomly assigned with respect to unobserved beneficiary characteristics given the observed controls. I'll show you some evidence on that in a second. What's the second piece? Well, that's going to be what we call a fallback condition. That's going to require that Zi and eta I are uncorrelated. So terminations have to shift consumers into plans that are typical in terms of their unobserved quality given observed mortality added. In practice, we can microfound this, so I can tell you what models of consumer choice are going to be consistent with this fallback condition. All right, so what does the exclusion restriction require? Well, it's going to require that Zi and epsilon I are uncorrelated. So what could go wrong here? Well, we could be worried that individuals in terminated low observational mortality added plans are actually becoming sicker faster than those in non-terminated low observational mortality plans. And in fact, that the firms know this, and as they have some private information about their consumers who are likely to get sicker, they might terminate those plans. Okay? In practice, we're not going to see evidence of those kind of pre-trends. Okay? And we've done a whole host of balance tests in the paper that give us some confidence on that first restriction. The second is the fallback condition, okay? And this is going to be new to our setting. The idea is that terminations shift consumers into plans that are typical in terms of unobserved quality given observational mortality added. We can microfound this condition. And so you can write down a discrete choice model of insurance choice. The basic thing that we would be worried about here is that we have some unobserved plan characteristic that's correlated with unobserved consumer preferences, or alternatively that there are unobserved consumer preferences over observed plan characteristics. In the interest of time, okay, I'm going to walk through this very quickly, but I'd refer you to the paper if you're interested. There are lots of cases in which the fallback condition is going to be satisfied. It will be satisfied under no selection on unobservables. It's satisfied under no persistent unobserved preference heterogeneity. It's going to be satisfied. We can allow for things like random coefficients, at which point persistence and plan utility can depend on observable plan characteristics. In that case, we need to observe on the condition on the observed characteristic. And last but not least, if there's monotone persistent heterogeneity, although I should say we're still working on the formal proof for this. Okay? So I think this is an interesting aspect of the paper, but not one that I'll spend a ton of time on today, okay? Because I want to get to some results. And so the first thing I want to show you is some first stage results. What we see in the first stage is that changes in the choice set lead to changes in predicted mortality added. This is that type of mean reversion that I showed you in that first diff and diff plot. If you're in a high mortality added plan and that mortality added plan terminates, you're going to be likely to be enrolled in a lower mortality added plan in the following period. That's going to be true across a variety of specifications. Here, I've highlighted the linear specifications because I think they're the easiest to interpret, but it's also going to be the case if we use above below median as in those figures that I showed you. Our instrument is going to be very strong. We're going to have good F-stat in the first stage. So we here between the last slide that I showed you, we've minimized the selection issue, and we still have some power to say something about mortality. Okay? Now, the next thing I'm going to show you is the reduced form. This is saying, do consumers who are in terminated high mortality added plans, we know they get moved into better plans in subsequent periods, are they in fact less likely to die as a result? And again, we're going to see a drop in mortality. What's interesting here is that the drop in mortality that we see, this is individual level realized mortality, it's going to be roughly of the same order of magnitude as our first stage coefficient, right? So just thinking ahead, we know that consumers in terminated high observational mortality added plans are subsequently less likely to die. The order of magnitude looks similar. Our IV estimate is essentially going to take this reduced form coefficient and divide it through by the first stage. Okay? And so that's going to give us that lambda in the model that I showed you. When we do that, what do we get? Well, we get a forecast coefficient lambda that's actually pretty close to 1. Okay, so there's some noise around that for sure, but it seems like those observational mortality added estimates are pretty good predictors of the true causal impact of plan enrollment. And we've done this again across a range of specifications, and we can do it with and without those demographic controls. Okay. All right, so I've now shown you that the observational mortality added estimates are good predictors of the true causal impact of plan enrollment. Of course, you should be sitting there and saying, what the heck is going on here? What about these insurance plans actually matters for enrollee health? And so we want to ask, what plan characteristics are potentially correlated with observational mortality added? Now that, of course, could be due to selection. We also want to know what observable plan characteristics are in fact predictive of the true mortality added. I'm going to focus today on some publicly available quality measures that the federal government puts out. So you should think of these as star ratings on a scale of 1 to 5, as well as financial characteristics, premiums, and loss ratios. Okay? So if you look at the observational estimates, so those mu, observational mortality added, and we plot star ratings against that observational mortality added, we see a negative relationship. Higher star plans, in fact, have lower observational mortality added. That seems good from the perspective of providing high quality information to consumers. But we can also just plug those into the same IV regression that I just showed you to see if those star ratings are actually predictive of the true betas. Okay? And in practice, what we see is while the star ratings are correlated with observational mortality added, so mu, they're not actually predictive. Okay? This is much noisier and smaller in magnitude of the true betas. Okay? And so in practice, we don't see that beneficiaries induced to enroll in 4- and 5-star plans are less likely to die, although we do see that the types of folks who naturally would enroll in those high-star plans are less likely to die. So while it's correlated with observational mortality added, we don't think that that's causal. By contrast, some of these financial characteristics really do seem to matter. Okay, so here I have both premiums and medical loss ratios, which are calculated as the percentage of premiums that you pay out in claims. And essentially what we're capturing here is that plans that spend more seem to do better. Okay? And so there's some correlation between the cost of the plan, how much they're paying out in claims, and the true mortality added. I think there's more to be done here, but I think it is interesting to see the extent to which financial generosity really does seem to matter. Okay? So we've done a bit more here, thinking about not just financial generosity, but network breadth and quality as well. Do I send you to good hospitals? And we find that those are correlated with true mortality effects. What's interesting here is I think that all of our findings are consistent with a broad and growing recent literature on the impact of not just health insurance coverage on your health, but also the form of those contracts, and also speaks to both hospital quality. Do I send you to high quality hospitals? And you have the sort of breadth of doctors available to you that might improve your health. And so I skip the literature review slide, but I think this is consistent with a large and growing literature. It's very recent, and so you can see that all of the sites here are in the past year or so. Okay. The last thing I want to tackle in the last couple of minutes I have is thinking about the effectiveness of consumer choice in this market. Okay. And so the question that we have here is, how well do consumers do at enrolling in plans that improve their health? And the estimates that we find are quite large in terms of the variation. And so you should be willing to pay a lot to enroll in a plan that is better than average here. And so we want to ask, are consumers enrolling sort of randomly with respect to the quality metric that we've developed? Or are they doing a pretty good job? And to do this, I'll do a couple of simulations. And I'll ask what happens to observational mortality added if we assign everyone randomly, and what happens if we assign everyone to the observably best plan in the market. To the earlier question, this is going to be a situation where we don't take account of capacity constraints. This is a very partial equilibrium exercise. We don't allow the insurers to respond. We just want to benchmark, order of magnitude. Could we expect better outcomes if we just resorted consumers across plans? Okay, so if we look at what would happen under random assignment, I'm sorry, this number is a bit out of date. Under random assignment, we see that mortality would in fact increase by about 5 or 6%. So consumers are doing better than random, but they could in fact do much better. Under optimal assignment, sending you to the minimum mortality plan, mortality actually decreases by about 26%. Now, if you're worried about those capacity constraints, or you're worried about the fact that I've essentially assumed normality to do this, you could do other simulations, things like moving people from the 75th high mortality added plan to the 25th percentile. That'll get you a 19% reduction in mortality. Or I can even randomly assign you to the set of plans that have lower than average mortality added, and that will also improve outcomes. So while we think that consumers are doing better than random, there's a lot that could be done to increase the quality of consumer choice here in terms of reducing mortality. Right? Why do we think that that's important? Well, if we're thinking about broad questions about whether we want to use markets and manage competition among insurance plans to improve outcomes, what I've shown you today is that there's substantial variation in insurance plan quality, and moving folks into better insurance plans would in fact reduce mortality. So that's sort of the potential here. Of course, the variation that we observe is going to be imperfectly correlated with consumer satisfaction and market shares. Okay? And what I showed you in terms of MLRs is actually going to be negatively correlated with margins. And so we want to think about not just consumer demand, but the implications that consumer demand has for supplier incentives. That's going to be important because demand is going to shape what products are offered, and ensure incentives to do things like invest in identifying good providers, whether physicians or hospitals, as well as to invest in things like clinical decision support. So I think this paper is sort of, I hope, the first paper in a broader research agenda thinking about how insurance and insurance contracts shape the care that we receive and our health as a result. Right. So thank you so much for your attention, and I look forward to your questions. All right. All right, good. There's a question about external validity. It's a great question. You know, I'm going to defend myself a little bit. I told you, I gave you the slide that said this is a big program, and from a policy perspective, I think we should care about this program in and of itself. I think the methods that we're developing here are really useful in terms of taking these methods for measuring quality and moving them into other settings. So I think there's sort of a fact here that's interesting, that there's a huge amount of variation in insurance plan quality. I think that is actually likely to be true across a variety of settings. And then we can give you a method to think about evaluating plan quality in ways that might be difficult if you're just thinking about the observational estimates, or alternatively about sort of an RCT or random assignment that is likely to be underpowered. So, you know, while you may not want to take, you know, the sort of last third of my talk as being portable to other settings, I think the first 2/3 really is sort of the simple fact that the form of insurance contracts has an impact on health. I think is likely to generalize, and then a method to think about investigating that. Good. Okay. So there's a question about moving people into traditional Medicare, so the federal plan, when an MA plan terminates. That's a good question. So absolutely, when your plan exits the market, you can absolutely switch to the federal plan. And then there's a question of whether or not there's heterogeneity in the impact of terminations in terms of people moving to the federal plan. So I do not have those numbers in front of me, but I have calculated them. The answer is like 85% of people in MA plans just switch to other MA plans, and it doesn't seem to be correlated with our observational mortality added. Although please send me an email, I can be more precise about that. There's a question about the premium number that I put up. The premium is the subsidized premium. So it's the premium facing the consumer. The reason to do it that way is in some results that I didn't show you, we can do a BSL calculation and think about the implied value of a statistical life that you would infer from consumer plan choice. And so for that, we really want to see the premium that is associated with the consumer. Furthermore, the subsidy is at the level of the market. So subsidies vary geographically, but they vary at the county level, which is the market that we have in practice. And so they'll be washed out by those county fixed There's a question of the choice of mortality rate of plans. So the mortality rate we think is the outcome that you actually care about, right? So why choose that as the outcome of interest? You know, I think that's going to be the health outcome that we're ultimately interested in. You could be interested in sort of morbidity and quality of life as well. I think that's going to be much harder to measure. So it's both, I think, of key policy interest and also easily observable. So we will have that readily available to us. And it's not currently being used in things like the star ratings that the federal government puts out. There's a natural question of whether you should just produce risk-adjusted mortality rates for these plans. And I think internally, my co-authors and I actually differ on the answer to that question. So, you know, out of deference to them, I will not opine wildly, but I think there's a natural question of whether or not you want to produce our mu estimates and give them to consumers. In terms of other potential outcome measures, are we planning for robustness checks? I think we're sort of pushing the data to the limit, and so I think there's not going to be a ton that we can do there. But I think it's an interesting question. So again, if you want to follow up via email, let me know what you have in mind. I'd love to chat more.
I think we can wrap up, Amanda. So thank you again for the findings. I'm glad that you took the questions yourself because there was some like muting, unmuting confusion going on, but now it's cleared out. I would like to thank you on behalf of IIM Ahmedabad and the Healthcare Economics Research System here in India, because I see a bunch of doctoral students joining not just from Ahmedabad, but other areas and cities in India to present your findings. And we really appreciate and are grateful for your talk. And we look forward to being in touch, and hopefully as things stabilize, maybe host you in campus in India one of these going forward months. Thank you.
That sounds perfect. I can't wait to travel again. So thank you so much for all of your kind attention. And I look forward to connecting with some of you offline as well.
Thank you. And we have recorded this talk, so we'll socialize the audio as well as the video content and keep you posted on the next steps. Thank you.
Great. Bye-bye. Thank you so much. Have a great weekend, everyone. Bye-bye.
Bye-bye.